Broadcast is now starting. All attendees are in listen-only mode.
Hello and good afternoon. Welcome to today's webinar, which is Protecting Your Health, Preparing for Flu Season in the Age of COVID-19. I'm John Muscedere, the Scientific Director of the Canadian Frailty Network and a critical care physician at Kingston Health Sciences Centre. In both of these roles, I see the impact of influenza on people's health. In the ICU, it isn't uncommon to admit patients with respiratory failure secondary to influenza, especially as the winter season comes on, and these people may go on to have prolonged illness and recovery or even succumb to their illness. In regards to frailty, as we will hear today, there's a high degree of vulnerability and potential impact of influenza. At the Canadian Frailty Network, our mission is to improve the care of those living with frailty, and then vaccination is an important part of this. Further, just to remind people that frailty is not an inevitable part of aging, and vaccination is an important preventative intervention that may keep people in good health. As such, it is part of the Avoid Frailty campaign, which is designed to promote healthy aging and improve the resilience of aging communities to events such as the current COVID-19 pandemic. The Avoid campaign stands for promotion of activity, vaccination, and influenza vaccination is a key part of that, optimization of medication, reduction of social isolation, and diet and nutrition. These are all evidence-based things that keep people to improve the aging process and mitigate the progression of frailty if it is present. Before going on with this webinar, I'd like to outline some logistics. This webinar will run for 1 hour and consist of 3 presentations followed by a question and answer period. If you have a question, please put it in the chat box, and if the question isn't answered live, then the answers will be posted to CFN's website, and a link to the website will be emailed to you. It is now my great pleasure to introduce our moderator for today, André Picard. André is one of Canada's top health and public policy observers and commentators. He has been a health reporter and columnist for the Globe and Mail since 1987. He is the author of 5 best-selling books and has won numerous awards for his reporting. Most recently, André was awarded the Owen Adams Award of Honor, which is the highest award offered by the Canadian Medical Association to a non-physician. So please welcome André to moderate the webinar.
Thank you, John, and welcome everyone to the webinar. As you know, COVID-19 has dominated the news for many months now. The pandemic's had a devastating impact on our health system, our economy, and of course on people. No one's been more severely impacted than our elders. Almost everyone who has died of COVID-19 is over the age of 65. Many thousands more have fallen ill. The vast majority of people who have died are frail elders living in institutional care facilities and others in the community. Now, as the population ages, we have to do a better job of protecting our elders from health threats like coronavirus and whatever new threats come along. But we also have to invest in avoiding frailty in the first place, protecting elders from everyday threats to their health like loneliness and inactivity, malnutrition, over-medication, and more. Now, today we're going to focus on one very important prevention tool, vaccination. And in particular, we're going to talk about the importance of influenza vaccination, especially given the pandemic, which is another respiratory illness. Now, we have an excellent panel to guide us through this topic. So without further ado, I want to introduce them. Each panelist is going to speak for 7-8 minutes individually. And then, as you heard, we'll have a question period, and we look forward to, I'll be monitoring your questions in the chat box. So our first panelist will be Dr. Melissa Andrew. Melissa is an associate professor of medicine at Dalhousie University in Halifax. As part of the Canadian Immunization Research Network, she's also the co-principal investigator of Serious Outcomes Surveillance, the SOS network, where she studies how frailty impacts both vaccine effectiveness and clinical outcomes of influenza and pneumococcal infections in older people. Welcome, Melissa. Right after Melissa, we'll have Dr. Shelley McNeil. Shelley is a professor of medicine at Dalhousie University. She's also the deputy director of the Canadian Centre for Vaccinology. Her research focuses on immunization policy and evaluation of the epidemiology of vaccine-preventable diseases in adults, with a focus on elders and pregnant women. Our final panelist will be Dr. Kieran Moore. Kieran is the Medical Officer of Health and CEO of KFL&A Public Health. And they're going to test my Ontario geography knowledge here. I think that stands for Kensington, Frontenac, Lennox, and Addington, if I remember my Ontario geography well. He also is a professor of emergency and family medicine at Queen's University and holds a master's degree in disaster medicine, as well as public health and a diploma in tropical medicine and hygiene. So as you see, excellent panelists. And Melissa, if you could kick us off, that would be great.
Great, thank you for the introduction. And it's an honor to be here to speak with you today about influenza in relation to frailty and function. I'm joining you from Halifax, which is in Mi'kma'ki, with the traditional territory of the Mi'kmaq people. So I'm reflecting on that today. So in terms of disclosures, I do have some grant funding and payments that come from industry to help support some of this work. So the three key things I wanted to share with you today in the next few minutes are these. So one is that the burden of influenza, we usually think about it in the short term, getting sick for a week or two, but then getting back to normal. But really, we want to think about that differently when it comes to older people. And there are complications, such as having a decline in one's daily function that can be persistent and permanent, getting worse in terms of level of frailty, and needing more supports like home care or nursing home. The second point is that older adults may not present with usual classic symptoms, and so their illness can be missed or misdiagnosed. And the third thing is that we want to think about how influenza contributes to worsening frailty, and on the flip side, preventing it can help us avoid frailty. So you may wonder what frailty has to do with influenza. We'll start with a quick definition of frailty, which is really just that somebody is vulnerable to bad things happening, and they're more vulnerable after even what other people might experience as a minor illness. For them, it could be quite debilitating. And that's just shown in the figure here, where someone who's frail to begin with can be quite close to that level of being dependent on other people. If they get a minor illness, they may get below that and may or may not recover. So that's just something to keep in mind. The data that I'll be talking to you mainly about today is from our Serious Outcomes Surveillance Network. It's a network of hospitals across Canada that Shelley McNeil and I are involved in, along with many other investigators. And we look for people admitted to hospitals with influenza, and also importantly, think about age-related issues such as their function and frailty. In the SOS network, we've measured frailty in a couple of different ways. One is to think about frailty as an accumulation of deficits. That just means more and more health problems and functional difficulties means somebody's more frail. The other way that we measure it is using something called the Clinical Frailty Scale, which puts people in categories. Just to go through it briefly, everybody is on this scale at any age, but essentially people who are fit and able to go about their daily activities without limitation are in these first three categories. People who need help with their basic activities of daily living get and have trouble with their mobility, walking around, for example, get more and more frail. So we categorize all of the patients who are admitted with influenza based on these categories. So just a couple of quick results to show you. So one thing is that we noticed that influenza vaccination tends to go up with age, which is a good thing. So the green in these pie charts is the percentage of people in the different age groups who are vaccinated. And so it is certainly a positive thing that more older people are being vaccinated. However, it'd be nice to get that number up closer to 100% in order to get the full benefit. We also know, of course, that as people get older, the risk of dying from influenza gets much higher. So in this graph, we can see, for example, that people over 75, about 14% of the ones who got hospitalized with the flu would have passed away during that hospital stay, which is much more, of course, than younger ages. And intensive care use is a whole different story, where older people may be less likely to go to intensive care despite their serious illness, perhaps because it's outside of what we would call their goals of care. When we look at this in terms of their frailty, the story gets a little more clear. So this is all people who are over age 65 now. Fortunately, again, vaccination does tend to go up with frailty, so people are getting the message that if they're frail, they need to, or have underlying illnesses, they should get vaccinated. But again, we need to get that message clearer. The death rate gets much worse, of course, as people get more frail, up to even 23% in the people with moderate to severe frailty. This infographic I made up to show the results of a number of different studies that we've done within our network. And it's meant to show this. So if we have 100 older adults who are living in the community, or some of them might be from nursing homes to begin with, but they have a certain level of frailty and a certain level of function at baseline, they get influenza and they're admitted to hospital. So what we know from our network over the years is about 12 of them will die. So 12% will die, which in itself is a very sad outcome. Here we see that about 68 of them will be able to leave the hospital with reasonably preserved function, meaning that they're able to function in their basic activities of daily living about the same as what they were. And when I talk about these activities of daily living, I'm not talking about doing your taxes or driving to the grocery store. I'm talking more about feeding yourself with food that's put in front of you, going to the toilet, getting up out of a chair, putting on your clothes. So the very basic activities. So 68 of our 100 people have had their function maintained. Unfortunately, 20 of them have had a decline in function that actually persists in the months after they've left the hospital. So when we break that down a little more, here we see that 9 of them had a mild functional decline. So that means they lost ability to be independent in 1 or 2 of their basic activities of daily living. But unfortunately, this group here of 11 people, so 11% of the initial 100 who came in, they have lost independence in 2 or more of their basic activities of daily living, which has been persistent, lasting well beyond their hospital stay. And in fact, 3 of them now have to go to a nursing home where they didn't live in a nursing home before. So all of these people with the functional decline, their function is worse than what it was when they started. Even if they had some dependence to begin with, it's now even worse. So you can really think about these people, the impact on their quality of life and the supports that they'll need from their families, from home care, or from nursing homes. And that's really what we want to get across as a key message, that influenza has this impact on people beyond the acute illness. As to the second point, when we talked about symptoms that people might have, we use this set of symptoms called influenza-like illness criteria or severe acute respiratory illness. And this has to do with having a fever and a cough. And we talk about these things with COVID as well. So they'll be very familiar to you. When we looked at our data of older people who've come into Canadian hospitals with confirmed influenza, we found that using the fever and cough actually missed more than half of them. So only 44% of 44 out of 100 older people with the flu who are sick enough to be hospitalized actually had the fever and cough. And it's a little better if we relax the feverishness definition to not be quite so strict. But it really just highlights that we can't wait for people to be sick with fever and cough. We need to think about the other symptoms they're presenting with, such as any sort of change from their usual level of function, level of confusion, and just kind of feeling unwell more generally. So hopefully this helps us understand that understanding frailty is really important in identifying influenza and appropriately treating it. And for example, putting people on isolation precautions in the hospital so it doesn't spread around. And understanding the importance of frailty in relation to influenza is really critical to understand the true burden. Really thinking about the increased care needs that people have, for example, from persistent functional declines. We're doing ongoing work in relation to COVID, so stay tuned for that. So overall, what we see as people become more frail, these are the level of the frailty scale, the 1 through 9. People do tend potentially to have a decline over time. And what we don't want is for that to happen. What we would like is for them to maintain their level of frailty or even improve. And in order to do that, we can do certain things, such as those things that are outlined in the Avoid Frailty strategy that John mentioned earlier. So I'll thank you for that, and I'll be happy to participate in the discussion afterwards.
Well, thank you very much, Melissa. Some quite striking data there. I think people don't always realize that, 1 in 5 people have long-term consequences of the flu, even those who don't die. So we'll talk about that a little more in the question period, but thank you for that data. Now, Shelley, I want to throw it over to you next. Thank you.
Thanks very much, and thanks so much to the organizers for having me. It's a great time to be talking about influenza and thinking about the importance of vaccination, as we expect to have influenza vaccines become available in the next few weeks. So begin thinking about getting out to get a vaccine. I have similar financial disclosures to Dr. Andrew, as we work closely together in Halifax, and we both do a lot of vaccine-related research. Dr. Andrew talked a lot about the very important long-term complications of influenza. I wanted to highlight, in addition to those, some important acute complications. So this is a respiratory illness and a virus that affects the lungs and can cause not only pneumonia related to influenza itself, but also can cause exacerbations or worsening of underlying lung problems like asthma, COPD or emphysema, bronchitis. And importantly, we also now have lots of evidence suggesting that influenza can precipitate things like heart attacks and strokes, and that the influenza vaccines that we use in Canada can prevent those complications. Influenza can also cause worsening of other diseases that seemingly are unrelated, like kidney problems or diabetes. It's as Dr. Andrew said, the majority of people who suffer the most significant complications of influenza are those who are older. But it's important that age alone is a risk factor, but if you have underlying other chronic medical problems such as heart disease or lung disease, the risk of ending up in hospital or dying from influenza are considerably greater. So about 5 times the risk of death due to influenza if you have underlying heart disease, and about 12 times the risk if you have underlying lung disease. And of course, if you have both, an even higher risk of death of about 20 times those who don't have those other chronic problems. This is important as we do see this reflected in the people who are admitted with influenza across our network that Melissa described. So about 40% of people who are hospitalized in Canada in our studies have underlying lung disease. About half are either current or past smokers, 16% have asthma, and about a third have COPD. And interestingly, despite the recommendations we're sharing with you today and that are widely and long-standing recommendations, only about 36% of people with asthma and 69% of people with COPD have actually received the flu vaccine the year that they're hospitalized. So we need to do a lot better at getting this vaccine to people who most need it. This is a particularly important and unusual year to aim to prevent influenza, as we expect to see COVID. Excuse me, as we expect to see COVID and influenza co-circulate, meaning both viruses will be around with us this winter, and both affect largely the same population. As André said, the majority of the most significant illness due to COVID-19 has been amongst older adults, and particularly those with underlying medical problems and those who are frail. We know that the healthcare system gets overwhelmed each winter with influenza alone. So we see lots of emergency room visits and about 12,000 hospital admissions due to influenza each year. About 2,000 of those require an ICU bed, and about 600, require a ventilator. And that just influenza alone every year, for those of us who work in hospitals, stresses the system. We have trouble keeping enough beds and ventilators and ICU beds, even just when influenza is around. Since just the beginning of the COVID pandemic in Canada, we've seen 157,000-ish cases about 12,000 hospitalizations, another 2,500 requiring ICU beds, and 470 requiring ventilators. So you can imagine that adding those two things together, circulating at the same time, it's very likely that our system will become overwhelmed. We don't yet have a vaccine to help reduce the risk of those things happening with COVID. So it's very important that we optimize what we're doing with flu vaccine, get it to as many people as possible to try to minimize the number of hospital admissions required for people with influenza, so that we don't have this double whammy as the season progresses. So even more important for people to get vaccinated this year than any year before. Lots of questions get asked about how well influenza vaccine works. It is certainly not a perfect vaccine. It prevents overall, though, about 60% of influenza infection. And we study, as Melissa said, we focus on older adults. And over the years, the effectiveness of the vaccine, or how well it works to prevent hospitalization, does vary. But on average, it prevents about 40 to 50% of hospitalizations. So given what Dr. Andrew said about the implications, the long-term implications of a hospitalization due to flu on long-term function in older people, preventing 50% of hospitalizations is a very important benefit. We have also seen reductions in the risk of ICU admission or need for a ventilator by about 50%, and the risk of dying from influenza is reduced by about 75% in people who are vaccinated. We also have been able to see that the vaccine reduces the risk of hospitalization for worsening COPD by about a third, and there's mounting evidence that we can prevent some strokes and heart attacks with flu vaccine. Of course, the immune system, as we age, gets less able to deal with flu and less able to respond to vaccines. And we do see some reduction in vaccine effectiveness, or how well the vaccine works, in the very frail older adult population. But it's important to remember that about most adults living in the community are not frail. About 24% are frail, but most are not. And amongst those who are not in the nursing home setting, or frail enough to be in a nursing home, the effectiveness of the vaccine is about as good as it is in most younger adult populations. So it's not all older adults are not equal, and we do see very good effectiveness in many older adults. One of the challenges of vaccination programs is, of course, trying to do better than the numbers I just showed you, and trying to overcome this weakening of the immune system that's associated with aging, which we call immunosenescence. And there's been lots of strategies designed to try to make vaccine more effective in older adults by better stimulating the immune response to a vaccine. So one of the strategies that's been used is simply to use a greater dose of influenza vaccine. So rather than using our standard amount of influenza vaccine, this vaccine, called high-dose vaccine, uses 4 times as much of the components in the vaccine that are protective. It's been around since 2016-17 in Canada. It is used in most provinces now in people who live in long-term care facilities, but may not be paid for publicly or free outside of nursing homes in some provinces. Costs about $65 to $88, but it has been shown to be more effective than our what we call standard dose influenza vaccines that most provinces routinely use for older adults. The studies with this vaccine, both the early trial type studies as well as the real world studies that looked at how well the vaccine worked, show that it's about 24% more effective than our standard vaccine. And importantly, that improvement in effectiveness extends into the very older adult population, so the over 75 population, and is still maintained in people who are frail. So this vaccine may have particular benefit as people are older and more frail. So coming back just to, in general, who should get a flu vaccine? So certainly everyone over the age of 65 or with chronic medical conditions of any age, residents of any age who live in nursing homes, pregnant women, Indigenous peoples, in all areas in Canada, as far as I'm aware, the vaccine is free for use in seniors. Again, we don't know, I don't know off the top of my head this year where we will be using high-dose vaccine or regular standard dose vaccine, and you can find that out in your own province, but certainly worth asking about. And with that, I'll stop and be happy to participate in the discussion at the end.
Well, thank you very much, Shelley. Some lots to chew on, and it'll give us some questions, especially want to talk about that high-dose vaccine a little bit more in the question period. Our next speaker is Dr. Kieran Moore, and I just have to say, Kieran, when I introduced you as the Medical Officer of Health for KFL-NA, I was challenged on the geography, and of course K stands for Kingston and not Kensington, as I said. So, but I do think of you as the King of Kensington or the King of Kingston. So, well, give the virtual floor to you.
I hope you can see my slides. Is that okay? Andre, can you
yes,
see
we can see them. Thanks. Yeah. Go ahead.
So again, yeah, thanks very much, Andre. I'm not the Kings of Kensington, but yeah, I'm in Kingston, Frontenac, Lennox, and Addington, Public Health. Thanks very much for the invitation. Full disclosures, I have no investments in pharmaceutical companies or vaccine manufacturers, and I have no conflicts of interest. I'm a salaried employee of a local public health agency. I do have an affiliation with Queen's University. I've been asked just to talk about the public health recommendations for this season. I couldn't agree more with Dr. Andrews and Dr. McNeil that this year, more than any year, is so important to consider getting the influenza immunization for all the reasons that have been mentioned. The emergency department visit volume always goes up when influenza activity occurs. The admission rates go up with influenza. In Ontario, in Eastern Ontario, we already have outbreaks of influenza B and influenza A in some long-term care facilities. So the virus is here. It typically starts propagating and rises in December. And so you do have a month or so to get your immunization in place over October or November. And the rollout in Ontario, at least, will be starting fairly soon with immunization available in primary care in November. There's in Ontario, for our 14 million inhabitants, we've got over 5 million doses purchased for our universal immunization strategy, with 1.3 million doses being the high dose vaccine that Dr. McNeil mentioned. So I am going to review NACI's recommendations. So the National Advisory Committee on Immunization is a central authority of experts who make recommendations for each influenza season. And I'll just talk about some of the practical tips we can all do to avoid any viral infection going forward over the next 6 to 7 months, which is important for all of us, given that this is a very unusual, unpredictable winter for us. And we need to be able to limit multiple different viral pathogens' effects on our community, including our elderly. So every year, we recommend influenza immunization. As Dr. McNeil's pointed out, we don't get 100% capture. Some of our long-term care facilities are excellent at getting very high capture rates of immunization of their clients and their staff. Certainly in our region, we're in the high 90s, very proud of that achievement. But we can do better across Ontario and Canada, with the rates only being in the 60s in some frail elderly. We can improve, and this year really is the call to action because the major benefit of prevention is that for influenza, we do have an effective vaccine, as Dr. McNeil has pointed out, and we want to avoid the complications, as Dr. Andrews has pointed out. So please consider the immunization this year. It is more important than ever. We want to maintain the acute care sector. We don't want them inundated with multiple different viral outbreaks, whether it's COVID, influenza, or the other typical winter viruses that circulate that cause harm in frail elderly. And please consider adopting the immunization strategy of influenza. So NACI has made the recommendation of immunizations for influenza. For 65 and older, which is our discussion this afternoon, they do recommend as the preferred product being the high dose influenza vaccine. And these numbers, IIV3, mean inactivated influenza vaccine. And when it's the number, it has 3 different viral particles in it to protect against 3 strains of virus, whether it's influenza A, and typically it's 2 types of influenza A, 1 type of influenza B. The high dose has that in it, and when you look at the number 4, it means it's covering influenza A, both the 2 types of influenza A and 2 types of influenza B. So my preference, if I had for myself and or any of my family, if they're 65 and older, would be for the high dose, given the effectiveness that Dr. McNeil has clearly stated. It's 24% more effective across age groups and should reduce the impact of influenza on the individual, as well as reduce the impact on the hospital sector, the acute care sector, for this season in particular. All of these, though, are very effective. At around 60–50%, preventing hospitalization, which is very important this year in particular. And all of them can be considered to be highly effective, but the preferred choice, as the NACI has recommended, is the higher dose vaccine if that's available in your province or jurisdiction. It so happens that anything we do to prevent COVID-19 will also prevent influenza transmission. So it's very important for individuals to adhere to all of these best practices. I know public health is inundating with these messages, but they're very important to adhere to as we go forward into this long winter, where influenza typically circulates now all the way through to the spring, with even influenza B being in March and April. Covering your mouth and nose with a mask whenever you can't physically distance will prevent transmission of most viruses. In particular, influenza and COVID are spread the same way. Cough and droplets are the main means of transmission of those 2 viruses. Fomites, so contacting surfaces, is probably less than 10% of influenza transmission. Just like in COVID, it's less than 10%. So masking in public when you can't physically distance, absolutely important. Good hand hygiene when you put on your mask or take off your mask. And when you touch any surfaces, wash your hands after, will reduce your risk of transmission of COVID and influenza. Certainly covering your cough, because influenza and COVID are spread through cough and droplet, will protect others around you. Cleaning surfaces, absolutely essential. Staying at home if you get a fever, a cough, increasing shortness of breath, calling your healthcare provider, asking if you should get assessed and tested. Most testing centers won't have an ability to test for influenza. They mainly are going to be testing whether you have COVID or not. But in outbreak modes, we will have the capacity, especially in long-term care facilities, retirement homes, to test for the presence of influenza, and potentially also offering an antiviral medication if you've been diagnosed with influenza within a certain time frame. So those basic precautions will help us for influenza and COVID. COVID's actually more infectious than influenza. So if we're doing well as a community at reducing the community spread of COVID, we'll do well at reducing the community spread of influenza. Australia and New Zealand have had, according to our knowledge, as they're just finishing their winter, had a reasonable influenza season. These best practices have kept influenza transmission at a low level. They also had a very high influenza immunization rate this year, much higher than previous years. So that combination of these best practices on prevention with immunization really does give me hope that we can avoid a high impact of influenza and concentrate on just trying to limit the spread of COVID-19, as many areas of the country have started their second wave of COVID-19. Just a reminder that these basic practices, the rule of C's, is exceptionally important. It will prevent influenza as well as COVID. So you want to avoid closed spaces, especially where there's closed ventilation. That will allow the contact and droplets to be spread more easily for COVID and influenza. You want to protect yourself about going to crowded places, another C, where you'll be exposed to multiple individuals who may be harboring the virus. It's important to remember influenza, just like COVID, can be spread before you develop your fever, your chills, your cough, your increasing shortness of breath. So there is an asymptomatic transmission of influenza, and avoiding crowded places, even with people who are asymptomatic, will be very beneficial to limiting your risk for COVID and influenza. And certainly close contact, shorter than a meter, increases your risk. 2 meters is even better for the contact and droplet precautions. So keep adhering to these best practices, and it will protect you for both of those high-risk pathogens this winter and spring. And just to go over some of the risks for members of our communities across Canada, low-risk activities, if you're getting your mail and packages outdoors, fresh air, those are low risk. If you're going to large venues like grocery or retail shopping, where public health measures, universal masking is in place, people are hand washing as they're going into the facilities, that is low risk. And certainly outdoor activities in the community with fresh air are low risk. And we absolutely encourage you to get out, do daily walks, enjoy the fresh air, especially before the surfaces get slippery or the snow starts to fall. Now's the time to really tune up your cardiovascular conditioning to prepare for this long winter that all of us have to endure every year. Medium risk activities, getting your nails done, going to a hair salon or barber shop where you're, that rule of C's, you're getting into a closed space, crowded places, and there's close contact. Anytime you see that, you got to be monitoring your symptoms, making sure that there's physical distancing, that you're wearing your mask and doing good hand hygiene. And certainly higher risk activities this winter will be difficult. We're already seeing in Quebec, and I'm sorry, André, the bars and nightclubs are closing. Some of the gyms, anywhere there's large groups gathering, have been stopped. I would anticipate if our rates in Ontario keep going up, that some of these public health measures will be put in place, and certainly hand hygiene going to be exceptionally important going forward. Another way of looking at this is staying at home, getting outdoors when necessary to maintain your physical fitness, your activity levels, are low risk events. As you get outdoors where you're meeting others that are unknown to you, that increases your risk somewhat. As you go indoors, the clock's ticking, so when we do public health investigations, it's more than 15 minutes with an individual in a distance of less than a meter makes you a high risk contact if you've been in direct contact with someone we further diagnosed with COVID-19 or influenza. And then large group settings, indoors or outdoors, just increases your risk. So please understand your risk. Now is the time to start getting your chronic medical condition under control. Have that virtual consult with your healthcare provider. Make sure you understand how to use rescue medications if any of your underlying chronic conditions get worse, and understand how you can limit your risk of transmission of both COVID-19 and influenza as we go forward into what's going to be quite a complex winter and spring, trying to deal with 2 major pathogens. The best way you can prevent your risk for influenza and take that off the risk stratification is to get immunized. And I think the presentations from Dr. Andrews and Dr. McNeil really highlighted the importance of immunization for influenza, the benefit of it. And I know all provincial territorial governments are going to be very aggressive in making the immunization accessible and available. Certainly we're planning that within our region, and Ontario's unveiled their immunization strategy. So be aware of what's available in your community, start planning to get immunized, and also monitor your daily health going forward. If you develop any signs and symptoms of a respiratory virus, please contact your healthcare provider, know where the assessment centers are and what their testing strategies are. And I'll stop there and join the general discussion.
Great, thank you, Kieran, and welcome back, Shelley and Melissa, to join us for the discussion. So there's a lot of questions, so I'm going to plow right into them. Maybe, Kieran, I'll start with you. Being asked, the influenza precautions, the COVID precautions are very similar. So if I wear a mask and I wash my hands and I socially distance, do I still need the vaccine?
absolutely need the vaccine. It seems to have worked really well in Australia and New Zealand, and it should add an additional benefit of protection, especially when you're in your small social bubble, and that bubble definition is changing. But there is that risk of transmission, that especially asymptomatic transmission of influenza. We really want to eliminate the risk of influenza this year or decrease its impact on individuals and the health system. And so I really do think it's absolutely necessary for anyone at risk in our communities to consider immunization for influenza and get our immunization rates the highest they've ever been. That's what Australia and New Zealand did, and they've had a very decent and reasonable influenza season this year. I think we can do the same.
Now, you mentioned Australia, New Zealand, that the Southern Hemisphere gets the flu first. They had a lot less flu. Can we count on that? We're going to have less flu because of all this COVID caution?
Well, they did it because they had good, well, in many areas they were in lockdown, and that's certainly going to decrease the risk. But hopefully we won't have to go into lockdown. And if we adhere to these best practices of masking, physical distancing, hand hygiene, plus immunization, it really could put us in a very good position going forward. I'm absolutely encouraging it for our community to have the highest immunization rates ever. And I think Dr. McNeil clearly pointed it out. Our health system will have extreme difficulty dealing with both an influenza outbreak plus COVID outbreak. The complexity of it, the impact on the healthcare system, the intensive care capacity, long-term care could be extreme. We really try to have to take that off the table, limit it as much as possible, and adhere to a strong immunization campaign this year and best practices to prevent both infections.
Yeah, we have a pandemic. We don't want a twindemic, right? We don't want to go to that next step. So, Shelley, lots of questions about high-dose vaccine. People have really twigged to that area. So I want to start, I guess I'll start with the really most technical question that's come, and we'll go into more simple stuff. But someone has said, you mentioned the relative decrease was 24%. What's the absolute benefit of the high-dose vaccine?
That's a very difficult question to answer because it depends on how good the standard dose vaccine is. So it's almost like a sliding scale. You know, the better the standard vaccine is, the less the absolute benefit of the high dose vaccine is. So it might be 10% in some years. It might be as high as 20% or 24%, depending on what the base is. But my point when I talked about frailty and the older adults, the over 75s, is that's where that absolute benefit will be largest, because the standard dose vaccine doesn't work as well in that group. So if you're very frail or you're 85 years old, where we would expect the effectiveness of the standard dose vaccine to be low, that's where you'll see the most benefit of the high dose vaccine.
Okay. Another question about the high dose vaccine, I'll throw again with you, Shelley. People are wondering, is this a live vaccine? You know, the fact that it's a higher dose, does that mean they're going to catch the flu from it?
Yeah, so no, none of the vaccines we use for adults in Canada are live vaccines. So you can't get influenza from any of the vaccines we give to adults in Canada. They're all made from bits of the vaccine, bits of the virus that can't cause disease. The difference between the high dose vaccine and the standard dose vaccine is really just how much of the bits are in there, sort of with the principle that if a little bit of this, what we call the antigen, the protective part of the vaccine, works, maybe giving more of it can help the immune system respond better. So sometimes people will get a little bit more of a sore arm, for example, with the high dose vaccine, but they would not get the flu from it, no.
Good. Now, Melissa, we talked a lot about the influenza vaccine, but there is some mention all along the way of pneumonia, of pneumococcal. Should people also get a pneumococcal vaccine, especially people with frailty?
Yeah, certainly. That's a great point. And back to what we see as some of the complications of influenza, that can include pneumonia. So you can come into the hospital with influenza and then get pneumonia from a bacteria on top of that. So there are vaccines that are available for preventing some types of pneumonia, and they would certainly be advisable to get, if you're in the category of people who should be getting those, such as people over 65 or people with underlying health conditions, then definitely talk to your healthcare providers about getting those as well.
Great. And a lot of questions about not everyone understands, why do we need a flu shot every year? And I'll combine that with people are saying, if you get it every year, does that make it worse for you, better for you? Is there any cumulative effects, positive or negative, of the flu shot year after year?
That's a good question, and I'll get others to weigh in on it as well. But essentially, there are a few different reasons for getting the flu shot every year. The main one is that it changes every year. So there's a big exercise that happens around the world trying to predict exactly which strains of influenza are going to be circulating, and that changes year to year. And so the flu shot it's like a update in your app. I mean, it updates the shot every time to cover the best estimate of what's going to be in the shot. There's also some suggestion that getting the shots multiple years can help stimulate other parts of the immune system, such as some of the cells that are involved in fighting off the influenza, in addition to the antibodies. So there's some suggestion that repeated exposure of the tiny bits of virus that are in the vaccine can help you if you get the vaccine every time.
So my mom had COPD, so I've had the flu shot for about 30 years now. That's not a bad thing. That's actually a good thing for me.
Right, yeah.
Great. And I love that analogy of like updating your app. That's a good way of looking at the flu shot. John, I want to bring you in. Thanks for joining us. People are wondering about, visiting their relatives, people living with frailty, living in institutions. Do they have to get a flu shot to go visit them in a home?
Mute.
You're muted.
You have to unmute yourself.
Great. So thank you for the question. I think it's much more preferable to have the vaccine, but it's also incredibly important, as Kieran outlined, to practice all the preventive things that you can do, such as wearing a mask, hand hygiene, and everything else. And vaccination and all those other things that you can do are a package together. So that would be the ideal thing, to both have a vaccination and practice all those other things.
And we're talking about the flu, but there's some questions about just frailty in general. People mentioned, what can I do to keep my grandmother, my elderly mother from degenerating like that chart showed? Is there practical stuff I can do as a loved one?
Yeah, no, that's so that's why at the Canadian Frailty Network we come up with the Avoid campaign, and there's good evidence behind all the strategies, all the components of Avoid. So activity, vaccination, making sure that you're on the appropriate medications for your stage of life, remaining socially engaged, reduction of loneliness, and the importance of diet, nutrition, including supplementation of vitamin D, are all really important things that you can do, whether you're frail or just becoming older. If you're becoming older, doing those things will prevent frailty. If you are frail already, or you have manifestations of frailty, then doing those things may actually prevent the progression of frailty, prevent you from getting worse. And there will be more things as we go forward, but as a public health point of view, those are all simple things that can be done in conjunction either by yourself or, for example, a vaccination and optimization of medication in conjunction with your healthcare provider. And surprisingly, they're simple, but a lot of people do not take advantage of those things, or those are not done. So, for example, we heard that vaccination, not everybody gets vaccinated. A lot of people, as they get older, their diet changes, they become less active, they accumulate the number of medications. So all those things addressed as a package are really important to increase the resilience as we grow older. And as a population, if we do those things in the majority of people, then we will be much more resilient to any future pandemics once COVID is over.
Now, Kieran, John mentioned in passing vitamin D. I spend a little too much time online, so I see a lot of enthusiasm for vitamin D, preventing the flu, preventing COVID. Is it a magic pill, vitamin D?
I don't think there's any significant evidence to support vitamin D as an anti-infective. For individuals that have osteoporosis or have documented deficiencies in vitamin D, it may be appropriate in those instances. And certainly, as we head into the northern climate and reduced exposure to natural sunlight, it may be appropriate to do supplementation during the winter months. But to my understanding, there's been no significant analysis that shows benefit from it as an anti-infective at present, and I would want the support of my colleagues on that.
Okay.
Not that I'm aware of, no.
Good. Great, thanks. Shelley, there are also some questions about COVID, obviously. People are wondering, we're talking a lot about the flu vaccine. It's been around a long time, but when is the COVID vaccine coming?
I wish I knew the answer to that one, but certainly we know that there are 10 vaccines at the moment in the world that are undergoing late stage testing. So the testing that would be done in large numbers of people in areas where there's COVID, lots of COVID, in order to be able to get a sense of how safe the vaccines are and how well they work to prevent COVID. So 10 vaccines, different types of vaccines, different technologies. So we hope that one of those, or hopefully even more than one of those, will show good safety and good effectiveness. The government of Canada has agreements now with I think 6 or 7 of those companies, so that if one of them work, they will be able to get vaccine for Canadians. Lots of steps between now and then, though, that need, Health Canada needs to approve the safety and the effectiveness of the vaccine. We need to be able to make the vaccine, deliver it to people. So I think, again, I'm kind of an optimist, but I would say certainly not before late winter, early spring, and the highest risk people would we start to see any use of vaccine, and that may be even a bit optimistic.
And this vaccine, obviously very important to people living with frailty. Are they being included in clinical trials?
I don't know all of the protocols. Often that group is largely excluded from clinical trials. I know some of them are including older adults, but I must confess I don't know the details of all of the studies.
And Melissa, I wonder, people are wondering, will the COVID vaccine, when we have one or several, will they have the same limitations as a flu vaccine? Will they work less in older people because of these immune issues?
This is a great question, and we'll look forward to trying to find that out over time. One thing to consider, as Shelley mentioned, is once we take into account people's frailty and underlying health, age isn't necessarily the biggest problem. So it's not that the existing flu vaccines don't work for every older adult. It's in fact, if you're a relatively fit older adult with less frailty, they'll work fairly well. And we really need to target our efforts at improving the vaccines so that they'll help the frailer people. It's also really just important to think about these vaccines as a general strategy to be trying to avoid frailty. So we'll have to see, and we'll have to be carefully assessing the frailty of the people who are receiving the vaccines. The other thing too is that some vaccines actually work just as well in frail people as in non-frail people. So it depends on the technology that they're using in their particular vaccine.
And there's a lot of new technologies being tested with these COVID vaccines.
Yeah.
And Kieran, again, to come back, some people are wondering, well, I'm young and healthy. Why do I need this vaccine, this flu vaccine? Is it to protect my granny? Is it to protect me? What's it for?
Well, there is a protection of the individual, so there will be an individual benefit. And I don't know if you've ever had the flu, but it's nasty. It's sudden onset fever, chills, muscle aches, joint aches, cough. You are out typically for several days. And certainly if you've got comorbidities, those underlying illnesses could be exacerbated, made worse, and in some instances end up in hospital. So there's the individual benefit, so presenteeism, not having to miss work. There's also the benefit of that cocooning. If you do have frail or older people around you, you not only benefit yourself, you benefit that you're not going to do that asymptomatic transmission to others that you care for. So in multi-generational homes, I would suggest everyone in that home get vaccinated. Anyone being exposed to someone who could have a bad outcome from influenza really should get immunized. And it's mainly that asymptomatic transmission. And that's why we encourage all healthcare workers to get vaccinated, because of that very risk of in the 24 to 48 hours before they get the true symptoms, where they're probably going to stay home, they can inadvertently spread the virus in a healthcare setting. So for all those reasons, we're looking at a broad-based high uptake this year, especially if you've got anyone that you care for that has any underlying illness or risk.
So things like COPD, asthma, heart disease, all those things, if people in your family have them, help protect them.
Any illness with the word chronic in front of it, you can get immunized.
Yeah. Shelley, another question about people are saying, I hear the word it's a good match or it's not a good match. Is this year's flu shot, is it a good match?
We don't really know this year yet, because as Kieran mentioned, we didn't see much influenza activity in the Southern Hemisphere. And we won't know until we see flu circulating in Canada which strains will circulate. So it's too early to say. Most provinces are using the 4-strain vaccine, so 2 influenza A strains and 2 influenza B strains. Often when we hear about mismatch, it's related to that B strain, the influenza B. So by having both, hopefully that minimizes the risk of mismatch. But it is too early to say. And that being said, you know, when I showed you the 40 to 50% of hospitalizations prevented, that was over many, many years with varying degrees of mismatch. So it represents kind of the average expected benefit, as opposed to, you know, how well did it work against this strain this year? And I think from my perspective as a physician and a daughter of older parents, that's sort of what I need to know is, on average, how good can I expect this to be, recognizing some years are better than others. And if I know that I can prevent about 40 to 50% of hospitalizations in older adults and all of the badness that comes from those that Melissa mentioned, I think that's the most important thing, as opposed to worrying about, you know, how effective was it against the B strain this year and the A strain last year. You know, we pay a lot of attention to that, obviously, as vaccine researchers and scientists, but what my mom needs to know is that on average, I can reduce her chance of hospitalization by about half.
And John, we know there's some questions about long-term care residents. We know that, again, they've been really hard hit by COVID. They're hard hit by the flu every year. What can we do this year to make it just a little safer for people in institutional care?
That's a great question. I think that the major things that we've talked about is vaccination, really careful attention to infection control measures in each institution, making sure that visitors also apply those same infection control measures. And the importance of infection control can't be underemphasized in those type of institutions. And that's something that I think over the years and that we haven't paid as much attention to as we probably should have. And the most important thing from a long-term point of view is to avoid winding up in a long-term care institution, and adopting strategies that we keep people in their home environments and prevent the institutionalization of older persons, which it does not have to happen. And there's other countries that have been much more successful than we have at that.
Right. Now we're almost out of time. I always like to end a panel on a more positive note, send people home with a positive message. So I wonder, Melissa, tell us what gives you hope that we're going to do better with the flu this year.
Well, there's much more awareness. I think events like this are really helping. And, you know, you can't turn on the news without hearing some message around that. So hopefully people are understanding the importance of prevention, and we can apply what we know about COVID, or what we're being told about COVID, to what we're being told about the flu. And also there's so much research that's gone into finding COVID vaccines and also improving influenza vaccines over time. So I'm confident that we'll be able to do better as we go forward.
Great. And Kieran, I'll ask you the same question. You've already been upbeat, but you're looking forward to tackling the flu this season and in your area?
Yeah, I do think it's a positive message. I think we can limit the effects of influenza. We can learn from Australia and New Zealand. We can have a higher immunization rate. I know there's increased interest by our primary care providers to provide it to their patients. So I think that's a very positive message. People are very interested in prevention and don't want to have us deal with the double whammy of influenza and COVID. And so very positive messaging from the community, from our primary care providers, our immunizers. They're all on board and we're ready.
And Shelley, you were very positive about the COVID vaccine coming. Tell us a little more about that. Something we should be looking forward to.
Yeah, no, I think the big positive for me coming so far from the pandemic has been the better education of all of us about the importance of these really easy things we can do to protect ourselves. Some of us have been harping on those for years about influenza, but it's taken a pandemic to really get the message out. I think we've really strengthened public health in Canada. Through this pandemic, we've added resources in long-term care and in infection control and in public health. That's going to stand us well for any infection. And I am very hopeful that, you know, we have some of the best and brightest minds in the world in Canada contributing to vaccine research for a COVID vaccine. And as Melissa said, for better flu vaccines. And I think we're just going to get better and better in our ability to prevent these infections moving forward.
And John, if I could leave the last word to you about frailty, this pandemic has shone a light on elders, particularly elders living with frailty. Are you hopeful we're going to start taking this demographic more seriously?
Absolutely. I think that this is a wake-up call, and I'm really, and just from the conversations that are happening, I'm really encouraged that maybe we'll make the necessary changes and embark on the necessary public health approaches to frailty, such that we can improve outcomes and quality of life in this rapidly growing segment of our population.
Great. And finally, I want to thank everyone, the attendees, for signing in today, for listening in on a really informative, thoughtful discussion. And again, we'll be posting this on the website of CFN, which is cfn-nce.ca. So the video will be posted, the slides will be posted, and we'll be answering the questions that we didn't get to in our very brief hour. So again, thank you to Kieran and Shelley, Melissa, and John for joining us today. And goodbye, everyone.
Very much.
Thank you.
Bye-bye.
Bye-bye.